Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare Communications, and I'll be your technical producer for today's webinar. The title of today's webinar is Respiratory Device Pressure Injury Recommendations from the Secure Prevention Consensus. Before I introduce our moderator, Lexi Caraway, and our speaker, Dr. Black, I would like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. And if you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. I would like to introduce our moderator, Lexi Caraway. Lexi is a registered respiratory therapist at Carl Richland Memorial Hospital in Olney, Illinois. Lexi is an active member of the Illinois Society for Respiratory Care's Board of Directors, serving as delegate and PACT co-chair. Recently, Lexi presented at the AARC International Congress on the topic Capturing a New Perspective on Pressure Injuries, Thermographic Imaging. Welcome, Lexi.
Thank you, Monica, for that kind introduction. The title of our webinar today is Respiratory Device Pressure Injury Recommendations from the Secure Prevention Consensus. Our speaker today is one of the nation's leading experts in pressure ulcer awareness and is a co-author of the Secure Prevention Consensus, Dr. Joyce Black. She is the Florence Needfield Professor at the University of Nebraska Medical Center in Omaha College of Nursing. She has received awards from UNMC and the college for her teaching. Her research areas of interest are in wound healing, specifically in pressure ulcers. Dr. Black's dissertation examined the patient and wound factors that contributed to healing or non-healing of diabetics with pressure ulcers. She is certified in wound healing and was inducted as a fellow in the American Academy of Nursing for her work in deep tissue pressure injury. Dr. Black is the current president of the National Pressure Injury Advisory Panel and wrote the seminal paper on medical device pressure injury. Dr. Black has disclosed the following financial disclosures. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. This activity is supported by an educational grant from Philips. And now I will turn our presentation over to Dr. Black.
Thank you very much, Lexi. I appreciate the opportunity anytime I can talk about pressure injuries to anybody who will listen. So thank you for joining us today. And also thank you for many kind comments about the emergency last week that prohibited me from doing this material. So what we're going to look at today is a group of very common devices that are associated with pressure injuries. And of course, in hospitals today, we are required to report them. We are required to notify sometimes the State Board of Health about them. And it's becoming a big problem. It's becoming a problem for the patient. It's obviously becoming a problem for us. And what you're going to hear from me is how important the team of the nurse, the pulmonologist, the intensivist, and the respiratory therapist are to make sure that these patients actually stay safe. I'm going to be following or being led by, and hopefully you will have access to some documents called the Secure Prevention Consensus work. That was some tremendous work that was done to really lay out what I think is a good plan for pressure injury prevention. A couple objectives that I hope to accomplish today. We're going to look at pressure and shear forces that lead to pressure injuries. We're also going to deal with microclimate. Microclimate may be a new concept for you, and I'm hoping to make it clear to you. And then, of course, the whole goal for this webinar is to explain to you and make recommendations for you and your healthcare team on how to really understand the problem of respiratory devices and their pressure injuries, and obviously how to prevent them in your patients. I think that's the goal for every one of us as healthcare providers. So the medical device related pressure injury was defined by some work that I did at the University of Nebraska hospital system, where we started to recognize that there were significant problems with pressure injuries in the critically ill patient predominantly. And we listed in our paper a large number of devices. And so we defined the condition as a pressure injury, so localized injury to the skin or underlying tissue, but this time as a result of the device. And therefore, one of the key features of this problem is that the injury takes on the shape of the device. So the patient you're looking at is a paraplegic who has an indwelling Foley catheter, and you can see the injury to the inner thigh and the scrotum from the catheter itself. Obviously, he also has an ischial pressure injury. On another day, we could talk about that kind of wound. These injuries are not minor. And I think that's one of the issues that we've had as a profession is we've tended to see these things as a minor problem, and they're not. They rapidly develop into full thickness injury, which leads to scarring, and of course, sometimes leads to the need for plastic surgery. So these problems were initially called medical device pressure ulcers. That's how old the topic is, right? In 2019, the NPIAP changed the name pressure ulcer to pressure injury, coming off a 2016 consensus conference. So the concept of medical device injury was changed to medical device related pressure injury. In that consensus conference, though, as many of you know, the audience said it's not just medical devices that lead to injury. It's glasses and hearing aids and stuff left over in the bed and all of these other devices that the audience really wanted us to pay attention to. And so we broadened the definition a bit. So today you'll probably hear the phrase device-related pressure ulcer or medical device-related pressure injury. I don't know that we have 100% consensus on what the phrase is, but I think you all realize we're talking about the same thing. The problem of medical device-related injury is actually pretty old. I found some literature over 40 years old that talked about bed sores of the ears, which is interesting, isn't it? Because just the word pressure ulcer was for many years called a bed sore, and before that called the decubitus ulcer. What we do know is that we're seeing more and more and more of these medical device related injuries. And we also know that of all of the litany of devices, our hospital at one time had 42 devices that were known to lead to pressure injuries. The respiratory devices really take the lead in their frequency, and that's why we're focusing on that concept. So here's the problems. The device that's placed on a patient, unlike a pressure injury from laying in a bed, you can't always move the device. You certainly can't always remove the device because they're placed for life-saving purposes, and sometimes they're placed for monitoring purposes. And so it's not quite as easy to prevent all of these as it is what we might call the traditional pressure ulcer. In addition, the pressure from these devices comes from the material that they're made out of, and many times this is very rigid plastic. I'm going to share with you some data that's brand new on this issue of how rigid the plastic is. Now, as I said a bit ago, microclimate also plays a role. Microclimate is the heat and humidity between the underside of the device and the skin. So when you think about a face mask, a CPAP mask, a BiPAP, there's a lot of expired or exhaled humidity in the respiration that collects inside of the mask, and that moisture against the skin reduces the tolerance of the skin for pressure and shear. You might know it as maceration. It's the same concept, except maceration would be literal damage to the skin. But microclimate is the phenomenon that leads to that type of injury. So then that tissue becomes edematous, and edematous tissue cannot tolerate pressure or shear. Well, unfortunately, all stages of pressure injuries can be caused by medical devices or devices in general. And you can see the categories, or what here in the States we call the stages of pressure injuries. These are all medical device induced. And so I think we have a big job ahead of us to reduce this hazard for patients. In pediatrics, the most common cause of pressure injuries in general are medical devices. And of course, the most common devices are those used to support respiration and ventilation. In addition, in children, and those of you that work with children certainly appreciate this, the child doesn't understand the need not to move and not to get the device off. So many times they're secured very tightly because you don't want to go back and put that device back on that child. But when that securement device is placed before any kind of fluid resuscitation of the child, you get a lot of edema in the tissue, and now the device plus the securement device leads to accelerated numbers of injuries. You can see some numbers at the bottom looking at non-invasive positive pressure ventilation leading to injury to the face, including necrosis of the columella. And if it's been a while since you've thought about the anatomy of the face, the columella is that tissue from the tip of the nose to the connection of the nose to the lip. Some of those children have required plastic surgery to repair that injury. So I also don't want you to think these are minor problems. So the secure prevention documents, there are actually two of them. You can see the covers of those devices, and it was a multidisciplinary group that put together this work. I was an author editor on them. I didn't put my name on the list. I did my work a little bit differently for that group, but they were published by the Journal of Wound Care, a journal, very, very good journal that comes out of London. And so I would encourage you to get these documents to help guide your policies and procedures in your facility. So the figure in front of you is one of the figures from the document. And I just want to talk through the mechanism of how pressure injuries develop. If you look at the top of the figure, it says external forces. And the one that's most important to me, probably because I like pressure injuries, is the word deformation. And that's talking about deformation of the cell. And if the deformation is intense enough, the cell will actually break and that cell will not come back. That's what we know to be the cause of deep tissue pressure injury of any kind, is the deformation of the cell and the loss, the physical loss of the cell. The one that you're probably more familiar with is what we were all taught in school, is that if you put pressure on tissue, you occlude the vessels in the skin and the skin dies. And that's still true, but it's less true than we thought for many, many years. We thought that was the only cause of a pressure injury. In reality, it's not. In reality, there's probably more of the deformation story than there is of the vessel occlusion. So what happens is the function of the skin changes, and the skin has an elevated loss of fluid through the skin called transepidermal water loss, something you can actually measure in the skin if you want to get into the research behind these stories. But the device injury then happens, and once the device injury happens, you have an open wound, you have inflamed tissue, you have pain at the site. I've already given you the idea, just kind of moving across this document, of microclimate. So microclimate, it is increased heat and humidity between the device and the skin. The temperature of the skin rises underneath the device. And that also increases the risk of pressure injury development in these patients. So what I'm sharing with now is some new data from Dr. Amit Geffen. Dr. Geffen is in Israel, and he's been working with us at Nebraska on this concept of why are medical devices so much the cause of injury. And so I don't want to share all of his data, but I want to share enough of his data to make you understand where our problem is in part. So what Dr. Geffen did was a series of experiments where he tried to measure how much compression could be applied to the plastic of a medical device. And so he put these devices on these plates to get a sense of how much pressure could the device take, and therefore how much pressure would be exerted against the skin. And you can see that depending on the type of tube, you get a different pressure pattern. What I really want you to look at is this next slide, though. I love this slide. So let me walk it through for you, starting on the left. And what he has done is calculated what's called an elastic modulus. So that is the elasticity of the skin. And you can see that on the left, he's got a blue arch that identifies how elastic human skin is. So you can see it there, that human skin is pretty elastic until it's edematous, and then it loses its elasticity. We often put dressings on skin to protect it from pressure. And so what you can see he did was he determined that with dressings in place, we still stay in the range of the normal elasticity of the skin. So now if you jump over just a little bit to the middle of the slide, you can see that various devices applied to the skin, medical devices applied to the skin, exceed the ability of the skin's elastic components. You can see the face masks are identified there for you, moving way over to the end. And I don't want to tell Dr. Geffen's whole story, so I'm not going to spend a lot of time on this. But if you move way over to the right, you see tube number 2 and tube number 5. Those are the endotracheal tube is tube number 5. And tube number 2, this is not going to be surprising, is the nasogastric tube. And so when we think about the range of plastics that are used on people, you can see that all of the plastics that are used exceed the ability of the skin to tolerate if we don't pre-dress the skin and if we don't change the device. And that's obviously where we're going. A huge contribution to the science of medical device injury. Here's a little more data on microclimate for you. And I've introduced the first couple points of the slide, so I'm going to jump to the bottom of the slide. As the temperature of the skin rises, this should make sense. The metabolic need of the skin for glucose and oxygen also rises. So every time that the skin rises 1 degree, there's a 10% need for more glucose and oxygen. You can see the problem, right? Problem's obvious now. As we put a device on the skin, the relative humidity or the microclimate rises. The need for substrate, oxygen and glucose also rises, but we can't deliver it because of the pressure of the device. And so this is really foundational for what we're going to be talking about for the rest of this material, is because we've created this situation of elevated metabolic activity, we have got to be able to alter the pressure patterns against the skin. And that's what we're going to provide for you in this example. So this is, again, the document coming out of the secure prevention documents. All I want to do is reinforce that this is going to be the guide for us going forward. We have to control the pressure of the device, and we have to control the microclimate of the device. So we're going to start with oxygen tubing. That's the old one. That was the one that was originally described. And When you think about standard oxygen tubing, there's a couple of things that should become real clear to you. Just think about holding it in your hand and pressing down on it. It's pretty stiff. We know that the incidence, so that would be the number of new cases of pressure injuries from oxygen tubing, can be as high as 37% of the pressure injuries of your hospital. So this is a big number. Now, what we found, and our poster child for this is the man at the top slide. He was our first case of medical device injury that we really dug into. And obviously this is a respiratory device. What we found out is that the little cannula that fits into the nares moved, and we actually watched some care being provided. And what was happening is our nurse techs were going in because the O2 sat monitor was ringing, and they would see that the oxygen delivery system, you know, the little prongs, were sitting over on the cheek. So they'd move the prongs back into the nares, and then they would crank up what I'm going to call the lariat. I'm sure Lexi has a more scientific term, but the device that holds the oxygen tubing secure under the chin. And it got tighter, and it got tighter, and it got tighter. And so this patient, actually, I don't have all the pictures of him. He has wounds from the device under his nose. He has wounds from the tubing behind his ear, and he actually has wounds from the device under his jaw. And that was all from us tightening and tightening the device. So the recommended prevention on this one, oxygen tubing is used a lot. So I think we need to be good on this. We need to inspect the ears. We need to inspect under the chin and under the nose. If the patient's conscious, ask if the tubing is causing pain. There are devices you can use to either pad the ear, so adhesive foam, just put a strip of adhesive foam behind the ear. There are also devices that can be affixed to the tubing to protect the ear. And when I talked to Lexi about this not too long ago, we both agreed that silicone oxygen tubing is a game changer for us because it's much softer. So if you're having problems with oxygen tubing, you might want to think about switching to silicone-based oxygen tubing. It is not, it's soft, but it's not easily compressed. So I think it's a good solution for this one. Now moving to some other respiratory device injuries. I'm going to jump now into BiPAP and CPAP, endotracheal tubes, and trach collars and trach straps. The problem with these devices is several issues. People's faces are not the same. In fact, I don't know if you've ever done this. If you take a photograph of yourself and slice your face in half on the photograph and flip your right side to be your left side, you won't look like yourself. So the right side and left side of your faces aren't the same, yet alone your face being the same as my face. So that makes it difficult to get these devices on securely and yet functionally. Now, on top of that, there's going to be no argument from this audience. The airway leads, right? When you talk about priorities, A for airway, it's right there. So there's always an urgency to maintain an airway, always an urgency for people who are dyspneic or apneic to get that airway open. So we often don't have the luxury of time to make sure that we've got everything perfectly managed on the front end. There's part of our issue, just our clinical issue. And then the other piece, when we use BiPAP and CPAP, is the seal of the device against the face has to be tight enough to provide the pressured air. If we get it too tight, we end up with wounds like we see in the upper picture, upper right, from the mask itself. And actually, fortunately for that man, we were able to move him to a nasal cannula. The picture on the upper left is, you can see the trach strap, and you can see that we moved it, but there's already a fully necrotic wound there. Fortunately, it was not terribly extensive because they can quickly get down into the vessels that supply the head and neck, and they can be fatal. We've already talked about my poster child. And then the patient on the lower right, that's an endotracheal tube ulcer that occurred obviously during intubation. And we were able to get him off of his ET tube and onto oxygen, just general oxygen. So we've got lots of device-related injuries. As I said, the respiratory devices are the most common type of medical device injury. And you can see some of the statistics, and these come from a multitude of writers, with 26% of the wounds behind the ears, 9% of the wounds from ventilation devices over the cheeks, the chin, the bridge of the nose, and then even the prongs of the oxygen tubing being almost 6%. Mary Arnold Long did a study in LTACs, and she found that up to 71% of her pressure injuries were due to CPAP and BiPAP devices. So I know that's where many of you are seeing some of your issues, and so we do want to talk about that in some detail today. So the epidemiology now, just kind of continuing the story, looking more closely at the non-invasive pressure masks, 19.2%, that's very high. And I'm very happy to be able to share with you today some of our best recommendations on how to reduce the problem. You can see another study by Kaiser, 35% of device-related injuries were due to all of the respiratory devices. And as I said earlier, in kids, up to 75% of pressure injuries are due to medical devices, not immobility in kids. So, I think there's really no doubt that we've got an issue and we have to tackle it. So let's move to the endotracheal tube. People have to be intubated rapidly sometimes when they are completely apneic or when they're rapidly desaturating. And so with the airway being number one, it is not uncommon for the issues of how do we keep the lips protected to show up afterwards. And, obviously we're all looking at how well we can ventilate them, how well we can get their SATs up, how well their gases come back. And skin takes a back seat. As much as I hate to say that, skin takes a back seat in this story, and rightfully so, because the patient's life has to be saved. The problem, though, is not minor. And what we see in some of these lip ulcers is that they become serious enough that patients need plastic surgery. They need what's called an Abbey flap. Perhaps you've seen that in your practice. And that's because they can't close their lips because there's such a hole in their lip from the endotracheal tube. And so here's where I really want you to collaborate with the respiratory therapist, because this is a multidisciplinary problem. This is not something owned by any one particular person. So one of the ways to prevent the problem is to use a device to anchor the tube. And you can see the devices used. These are patients of ours, the devices that we use to anchor the tube. The advantage of those anchoring devices is you can move the endotracheal tube without having to undo a bunch of twill tape and other things. You can just move it across. And our recommendation is that each time the patient is turned in bed, which is every 2 or 3 hours, the endotracheal tube should be moved. And the reason I say that is most of the time you have to deal with all the ventilatory tubing anyway. So you might as well do it all at once. You need to look at securement devices that can be loosened to make sure, again, we've got a problem with edema with some of these patients. So thinking ahead when you're selecting a device for your facility. But our hospital, we collaborate with the respiratory therapist, and between the two of us, when we turn the patient, or for sure every 12 hours, because obviously some of our patients are more difficult to move, you've got to move the device on the lip. Oh, I went too far too fast. I had it stuck and I jumped ahead. So let me back up one. I did want to spend a couple seconds just talking about proning patients. We learned how to prone, didn't we, during COVID? And we're not going to forget it because we saw the benefit of proning. If you've not proned patients with ARDS, you need to. It's amazing to watch how fast they recover. Now, COVID was, of course, a unique respiratory situation, but you should be aware of how to do this. So our recommendations on proning patients that are intubated, and of course that's the most common, is to not use those endotracheal tube holders that I had on the previous slide. The picture at the top is an injury to the face of a patient who was proned with the securement device. And the problem is the patient is laying on one side or the other side, and those devices are too stiff. They were designed for people who were supine. They were never designed for people who were prone. So I don't know if the companies that make those devices are coming out with securement systems for the prone patient. But the recommendation during COVID was to switch to twill tape, as is shown in the bottom, and then you don't have that pressure injury on the upper cheek. There's lots of videos on how to tape an AT tube. If it's something that your hospital is struggling with, you're fearful that the patient's going to extubate themselves if the tube is not held with a securement device, go downstairs to surgery and get the oldest anesthesiologist that you can find, because they've all taped ET tubes and they can show you how to do it. It's a perfectly fine way. I guess when you're as old as I am, that's how we did it for many, many years. And it really only comes into play with the proned patient. So just something for you to think about. So in the child and across the bridge of the nose, these injuries can happen really quickly because there's simply no adipose tissue. So when you think about the general pressure injury, you think about bony prominences, right? We had that all drilled into us. Well, the reason bony prominences break down is there's no fat on top of them. That's why they're prominent. I mean, it kind of goes together, right? So there really is no fat on the bridge of the nose and very little fat on the cheekbones. And so that's why the devices lead to pressure injuries so quickly there. The patient that you see on the right is a patient of ours that was on the liver transplant list, came into the ER. You can see how jaundiced he is. So we were hoping for liver transplant soon. But he had respiratory distress when he came into the ER, and also had a do not intubate order. Now, to be honest with you, I wasn't sure how he was going to go through liver transplant with a do not intubate order, but I figured that was a problem for another day. So he was placed in a CPAP mask in the ER. That was the bridge of his nose 48 hours later. He had seen it. He was not happy about it, obviously. And so we didn't really do much but get plastic surgery to see him debride the eschar, close the wound primarily, but a serious problem, not just because it's a wound, but in large part because it's a visible injury. And even though we can explain it to the patient and say, we had to do this to keep you breathing, sometimes they don't see it that way, right? So let's talk about prevention in patients in these various CPAP and BiPAP devices. One of the things that you can do, and you should do early, in fact, work with respiratory therapy if they are the one fitting the device, and that's usually the case, is to put a preventive dressing on the bridge of the nose, under the eyes, where the mask is going to go. Now, you don't want a thick piece of foam, because remember, part of the seal of this device is important. So we're working as a team now with respiratory therapy to make sure that we've got a marriage of skin protection and the right fit. Respiratory therapists are the best ones to make this determination, and many of them, including Lexi, because I actually talked to her before I did this presentation and said, I know that all respiratory therapists tell us that a small leak of air is okay from these devices. But I can tell you as a nurse, as a wound expert, I don't make that determination of what a small leak is, because many of the pumps that supply the pressure, once a leak is determined, they just increase the flow of air and it becomes really uncomfortable for the patient. So my guidance to those of you that are not respiratory therapists is let them tell you what's an acceptable small leak. Don't do that decision by yourself. They're the best ones because they know the pump. So in pediatrics, the recommendation, and actually this is going to be part of the recommendation for both adults and kids, is to alternate the type of mask used. So we have a number of masks available today that provide positive pressure to the airway. And the purpose of that positive pressure is to keep the airway from collapsing during exhalation. And even the obstructed airway patient has this kind of device. So what we want to do is we don't want to take the device off and eliminate the pressure, because then we put the whole airway at risk. But you can alternate the type of mask, and probably one of the most beneficial ones is the full face mask, which is what you see in the picture here, because you're really moving the pressure to a much bigger area. If you passed physics, and so I'm going to presume that a number of you did, you know that when pressure is applied to a small area, like the bridge of the nose, it gets very high. Look at the area that you have across the forehead, much bigger area, so the pressure overall is less. So the full face mask is really an excellent alternating CPAP to full face mask, and of course it changes the pressure distribution. Now, one of the things that will happen is that if this is a patient who needs to eat and is on CPAP, BiPAP, or the full face mask, obviously they can't eat or drink. And I want the nurses to work with respiratory therapy to be able to figure out what the conversion is if the patient goes, and they usually would go to a nasal cannula just to support their oxygenation while they're eating. Figure out what the comparable FiO2 is, or the percentage of oxygen is. Don't just automatically assume that you know that. Many of you have on the back of your name tag the conversions, and I'm not trying to diminish those of you that do this all the time, but I don't want you to just automatically switch a patient from a CPAP, BiPAP, or full face mask to 2 liters by nasal cannula, because I'm not positive that's a fair comparison. So be sure you work with respiratory to understand what's safe. Most of these patients aren't going to be on nasal cannula for long, because if they needed that positive pressure ventilation, obviously the nasal cannula is not that. So you do want to ask about pain from the mask, and that will help guide you about where to put preventive dressings, what type of alternating mask should go in place, because pain is one of our early signs of pressure injury formation. So, don't forget to ask about pain. So I love this drawing, or this chart, because there are various types of devices. There are positive pressure devices that rest across the bridge of the nose. There are positive pressure devices that rest under the nose and under the lip. And so you can rotate. There's multiple devices here. So it's actually better than it might sound, because you can change, even in the positive pressure delivery, some of the masks. And so what is shown in this diagram is how you can predetermine a rotation system for your patient, and it's an excellent approach. So rather than wait for pain, rather than wait for redness or blistering or ulceration, you anticipate that that's going to happen and put the plan in place. And of course, this is something that you would do with respiratory therapy, because they are the ones that totally understand which masks support the patient best and match their face best. So this is a preventive plan, and I think that's helpful, because obviously if we can prevent these injuries, we're by far better off. So I know that many of you work in acute care, and therefore you are working perhaps with NDNQI, the nursing database of nursing quality indicators. For those of you that don't do this, NDNQI is a very common reporting structure, and a lot of hospitals report their pressure injury numbers to NDNQI. And then what you get back, and those of you that do this know how this works, what you get back is how your data compares to other hospitals of size, of type. And so our data are compared to other academic health science centers, so we can see how we compare because we have the same types of patients. So right now, the data on the NDNQI is, does the patient have a medical device pressure injury, yes or no? Well, that's helpful, but it's not as helpful as you need it, right? Because if I said 37% of our hospital-acquired pressure injuries are from medical devices, the first thing you'd say to me is, well, like what device? Because if you're going to be part of the quality improvement team, it doesn't really help you to just know this binomial number of here's the rate. You really need to know the rest of the story. Are some of you old enough to know Paul Harvey? Maybe some of you are. He used to do this thing called the rest of the story. So at your system-based level, here's what I want you to start looking at. What's the actual device? So the manufacturer, the device, you may want to get the lot number in case you want to look at whether this was a poor lot run. But look at the device. So I wouldn't even want to hear we've got a lot of respiratory devices. Were they endotracheal tubes? Were they CPAP? What are we talking about? Because I need to develop a plan based on the device. I think it would be helpful, this is a little bigger data lift, would be to look at the number of days until the injury occurred. So patient came in on day 1, but they didn't have an injury till day 5, versus patient came in on day 1 and was injured already by the evening of day 1. Those are different stories and would tell you the urgency to change your plan. But then you also need to, as you develop this plan, or what a lot of people call today a bundle of care, you want to obviously reduce medical device pressure injury, respiratory device pressure injury. You need to start looking at how adherent the providers are. So this is going to be, again, in combination with respiratory care, did we get the right size product on? These masks come in different sizes. And if you don't get the right mask, the fit's going to be off. The injury could happen, particularly if you got it too small of a mask. Was the mask repositioned? Was the device repositioned? Do you have a program where you're routinely rotating the type of device? Do you have padding on the skin? And how long did it take to get that on? I can tell you that was one of our first obstacles to this whole thing, was we waited too long to get the padding on. And then, did somebody assess the skin? Did respiratory and nursing work together to assess the skin at each shift and really start to get a plan in place? So when you look at the secure document, this is what you're going to see. You're going to see a closer look at all types of wounds and how to prevent them. Here's some of the major themes of those documents. Most device-related pressure injuries are preventable. They're not all preventable, so be careful that you don't ask your staff to be at 100% compliance and 0% incidence, because I think that's a big ask. The device should be properly sized. It should be secured without creating pressure from the straps or the device itself. Obviously, every patient wants to be out of these devices, so removed as soon as possible. Is this padding done for the skin device interface? And then if the patient is prone, get them off of the device and use the proper head cushion for the patient. This is another figure from the secure document, and it just takes the word secure and breaks down each letter. So as we've been talking about, you need to do a good skin and soft tissue assessment under the device. obviously before, if you see a wound before, you're going to have to work with respiratory on where else you could secure the device. We've just done an hour of education for you. I'm hoping that you can take this education back to your staff and work on a plan for reducing. That plan comes through collaboration with the intensivist, the pulmonologist, the respiratory therapist, the nursing staff. This is a team effort. It has to be done that way. I think I spent some time with you today helping you understand the mechanisms of injury, that it's both a pressure problem and a microclimate problem. Your reporting structure is predetermined, but I do want you to start thinking about how to improve the quality of reporting in your system so that you can make the right changes. If your devices are leading to 100% pressure injury, you've got the wrong device or you're using it improperly. And that's the evaluation mechanism of the secure program. Oh, I turn it back to you, Lexi.
Thank you, Dr. Black, for a most informative presentation. I would now like to inform our viewers how to obtain their CEs for this session. This activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to www.sacstesting.com/BO. You will need to register on the test site and then complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Phillips. An archive on-demand version will be available on www.betteroutcomes.org. The on-demand version will be accredited for CEs. And now we're going to move on to our question session from our audience.
Lexi, can I ask you a question first? I know that you're a respiratory therapist, and here's what I want to ask you. I think there are a lot of people, a lot of static right there for a second. There are a lot of people that are in CPAP and BiPAP at home, and this is a guess to some degree. As they get shorter of breath, they probably turn up their mask, use their mask more often. Here's what I'm leading to. What's your experience with pressure injuries of the face that are present on admission because of the way the patient was using the mask at home? Have you got anything you could share with us on that?
Actually, yes. I was part of helping with a study at my former position, and we were noticing that a lot of patients who wear home PAP devices, specifically BiPAP, were coming into the hospital and developing pressure injuries a little bit more quickly than patients who didn't wear that at home. So what we started to do was use thermographic imaging, because we had that available at our facility, to screen the patients and then take pictures on admission. And we were able to actually identify pressure injuries that were present on admission, and thus help us protect the patient from them becoming increasingly worse when we applied BiPAP at the hospital, and also protect the hospital from losing reimbursement.
Oh, that's excellent. That actually doesn't surprise me that they had injury on admission. What is neat is you were able to detect it in a way that really provided, I hate to use the word evidence, but you know what I mean, provided evidence of damage at the time of admission. I had a feeling you might know something about that. So thanks for sharing that with the audience. I think it's crucial. I didn't mean to run into the audience Q&A, so I'll turn it back to you.
You're welcome for that. We have a couple questions from the audience. We have a couple, I'll kind of compile them together. Basically just like, are there any recommendations specifically you have for foam or any products for PAP masks to protect the skin that you would prefer?
Yeah, there's a couple of foams on the market that are relatively thin, but adhesive. And what you really don't want is a highly adhesive product. The reason is this is already damaged skin and you can't get it off. So I would stay away from the films. They're not going to help you anyway. You could use a hydrocolloid, but sometimes they're extremely adhesive. And again, you could end up damaging the skin by pulling the dressing off. So I would go to a foam, and there's a little bit of data on these foams that are relatively thin and have more of a silicone-based adhesive to it. That way because what you want to do is examine the skin. And so you're working against yourself if you're putting a product on the skin that you can't get off, or you can't get off without damaging the skin. So I would go to the foams, not a thick foam. You don't need the foam that you put on somebody's backside. You need a thinner foam. This is an area that I think we have a little bit of data on. I probably could dig it up. I should have probably put it in the talk.
One product that I think sometimes gets overlooked, and we started implementing, was using just a skin barrier wipe before we ever put the BiPAP on in the first place, if it wasn't extremely acute situation. Just a little wipe to just provide just a little bit more protection on that skin, and then reapplying that every couple days.
Yeah, that's a perfect way to manage the microclimate issue. So that's exactly what you're getting out of that. So good. You applied my information right off the bat.
Another question we have here is, with COVID and the mask wearing, did you notice any additional pressure injuries from damage behind the ears on patients who were wearing nasal cannulas and oxygen at home, and then who were very diligent mask wearers? Were you seeing an increase in pressure injuries behind the ears due to mask wearing?
Yes. What we found in a lot of our COVID patients is they had to go to high flow oxygen by nasal cannula. So there was just more need to keep the device on, and they desaturated more rapidly. So we were more intent about keeping even the straight nasal cannula on them. Yes, the pressure injury rates in all COVID patients are higher. The true pressure injuries as well as the respiratory device ones. We all struggled with that. And the NPIAP actually put out a number of documents on how to reduce pressure injuries in COVID patients because we could see the numbers rapidly going up.
Okay, thank you for that. We have another question here. This one is dealing in friction and shear and what we can do about it. And I know as respiratory therapists, when we add humidity to the circuit, we have to worry about that. And also with any sizable leak, we need to worry about that. So what do you suggest for worrying about that? And what are your thoughts on friction and shear?
Well, I think you captured it as far as every time you elevate the humidity, you increase the microclimate and the potential for problems with the skin. As far as friction and shear, probably the best way to do that is make sure the mask is secure, because a secured mask isn't going to move. What's moving is as the patient moves and as they breathe. If the mask is not secure, then it rubs against the face. That's the opportunity to ask the patient if they're having pain. And if they're having pain, what Lexi just said, as far as a skin prep, would be a perfect solution for friction and shear, more friction than shear. If you're concerned about shear, there's where the dressings would come into play.
I just have a comment to make here as a respiratory therapist. I think something that gets overlooked as a respiratory device that causes pressure injuries is sometimes the vest, the chest wrap. Sometimes I've seen that get left under patients, and the hoses for that, and also our BiPAP hoses, and circuits can get left. And we do have a question here from one of our audience members. Will the heated wire circuits create more facial pressure injuries than no additional humidity? And I think that goes with the I feel like that goes with the friction and shear that you just answered. But have you seen anything with like a heated wire circuit laying on a skin versus a non-heated wire circuit?
No, but I have seen injuries from the various apparatus getting left under the patient. I fully agree with that. but I don't have any personal experience with the heated devices. You probably have more, Lexi, than I do.
I think this is a very good question here from our audience. The question deals with dentures, and we are always, we're supposed to take the dentures out of the patient's mouth when you apply BiPAP. But a question here, and I think this definitely ties into pressure injuries, is the question is, do they aid with structural integrity and support the device success? I think when a patient doesn't have those teeth, I think they're more at risk of possible injury. What do you think on that?
Well, I think the mask wouldn't fit as well because the design of the mask was for people that have teeth. And when you take particularly the upper teeth out, you lose that support of the upper lip. And so the device is not going to fit as well, which is going to lead to increasing attempts to make it secure. So yes, I fully agree that that is an issue. That's a great question.
You have, we talked sort of about the very thin barriers. Do you have any opinions on using the gel pads under the masks? I know I've tried to use them, and sometimes they work and sometimes they don't. Do you have any input on that for our guests?
Well, to be honest, Lexi, I have the same issue because it's where the gel ends, and to try to get the mask to connect there, because, I'm sure that the audience is familiar with this. You want a continuous attachment of the mask to the face. And if you have a thick product, there's going to be a bump there. There's going to be a space there, and that's where the leak is going to come. So that's why I was saying before, you're better off not to use thick foam dressings, but thinner dressings and ones that can be easily removed because you don't have that very distinct bump between the edge of the gel. I agree with you, Lexi, depending on the anatomy of the patient's face, it may be something that works well for people, but I don't know that I would be able to say use it in patient A and not use it in patient B. But I can already see the issue with the connection of the edge of the gel to the mask.
Okay, and I have one last question here, and this one's from me. My question is, have you seen any studies, or are you familiar with any studies which correlate with your discussion on the elasticity of the skin and then correlating with the Braden score when a patient comes in? Have you noticed anything that, or do you have anything on that?
Well, that's a humdinger of a question. I think that needs some research. So the data that I presented from Amit Geffen is actually not even in publication. So his work is right hot off the press, if you will. In fact, there's no press yet, so it's just hot out of his lab. The Braden scale is probably not going to be helpful here. Because I've had patients that are completely conscious and just unable to breathe. And I've had patients that are completely comatose, sedated on propofol, both getting medical device injury. So I don't see how the Braden would guide that. There is a version of the Braden for children that asks for the identification. It's the Braden with a D at the end. And it just, again, asks you to say device present, yes or no. That's not enough to help us. So it's probably not the Braden, Lexi. It's probably going to be another predictor. I'm wondering about some of the predictors used for mortality and morbidity in ICU might be a better predictor for us to work on. I'll work on that with you, though.
All right, perfect. Okay, and at this time, I would just like to say thank you for attending this webinar. And now I'll turn the presentation back over to Monica for some concluding remarks.
Thank you so much, and thank you for your expertise. And immediately upon the conclusion of this webinar, you will be presented with an online survey. So please keep your browser open. We appreciate your feedback. And in 1 hour following the conclusion of this webinar, you will receive an email with the instructions and this link to obtain your CE credits, and that is www.saxtesting.com/BO. And we thank you all for attending, and everyone have a great day.